Welcome everybody. Kalispera from Athens, Greece. I'm Spyridon Vassilopoulos. I'm going to be your moderator for today's EFP oriented live webinar. And I want to thank you all for being here because I know that we are all trying to catch up with normality, those crazy coronavirus times. And of course, we're trying, most of us, to go back to work in our private practice or even at the universities, dressed like sweating astronauts with face shields, masks, FFP2, FFP3, if you can find them, I don't know. But all of these measures seems important for at least this period of time in order to stay safe and away from coronavirus attacks. And grabbing that situation here, and because I'm a member of the organizing committee of EuroPerio 10, I say that it's very important to stay safe if we want all of us to be together and celebrate the 10th anniversary of EuroPerio in Copenhagen in June 2021. So today we're going to have a webinar with which is corona-free, of course, but it's with a subject with a next best thing to know about sex hormones and if they have an effect on periodontal health. And our speaker is going to be Associate Professor Dr. Ali Çekici, who was born in Istanbul, and he was graduate and he has received his PhD degree from the same university. And also he completed his 2-year postdoctoral research at the Forsyth Institute in Boston, USA, in Massachusetts. Now he's working as an associate professor at the Istanbul University, and he's a board member of the Turkish Society of Periodontology, and he serves as the treasurer of this society. And also he has served as the ambassador for the EuroPerio Night. I had the luck to work with him during those times with a very successful EuroPerio in Amsterdam. And now he's going to be also the next ambassador for EuroPerio 10 in Copenhagen. So once again, to share the vision of EFP, which is to stay healthy, as I said before, and the well-being. And a very important ingredient for health and a better life is the periodontal health, of course, as we all know about it. And that goes through science and research, and then the implementation of the research, which is education and training, like the webinar we're going to have today. And just to remember the movie theaters, which I know that in many countries were closed those days, before the movie, you'll see the intellectual property. So all the materials here presenting these webinars, you have to know that it's intellectual property of the speakers and the EFP, and you are not allowed to modify, reproduce, transmit, publish, mean stolen. You cannot take it unless there is a written consent of the speaker and the EFP. And here is the topic, the sex hormones. Do they have an effect on the periodontal health? And here is our speaker. We're going to have, as you can see, 45 minutes, approximately 40 to 45 minutes of lecture. And then in the presentation, we're going to see the aim of the webinar, which is to give the clinician the insight to understand the effects of estrogens, progestins, androgens on the periodontal tissues, and mainly in the periodontal treatment. We're going to give a clinical point of view through Dr. Ali Çekici's knowledge on the sex hormones and the periodontal health impact. And in the end, we're going to have 10 to 15 minutes to answer any questions. We should try to answer as many as we can. And then we'll proceed with closing remarks. And that's all for me so far. So now I would like to ask Dr. Ali Çekici to share his screen and his knowledge with us. Dr. Ali, welcome. The screen is yours.
Thank you, Spyros. Can you hear me well?
Very well.
Okay. I'd like to first thank you for this wonderful presentation of myself. And it is a privilege for me to work with you in the EuroPerio once again. So I hope this crisis will be ending until then, and we will be celebrating together again. So since we have limited time with this webinar, I would like to start immediately. Yes, you have shared the topic with our viewers, so I will try to go on with my next slide, which will show what I'm trying to present tonight. I will try to cover these subjects. At first, I'd like to talk about a little bit of the general effects of the sex hormones on periodontal tissues, as we know. But on the second half, I'd like to share some scientific knowledge about the changes in sex hormones and how they affect the periodontal health, especially in specific timelines or periods in a person's life, like puberty, during the menstrual cycle, or in pregnancy and menopause, and also changes in testosterone levels, how they affect the periodontal tissues. Hopefully I will be covering those. But before I go on further, I should mention that hormones and their changes in life is a normal thing. It's physiological. This is not a disease we're going to talk about, but it might have some effects on the diseases that we know as gingivitis or periodontitis or other periodontal conditions. So let's keep in mind that what we are talking about is not a disease, it's a physiological condition, and it changes through lifetime. So I'd also like to mention the new classification of periodontal and periodontal diseases and conditions also covered the sex steroid hormone effects on the periodontal tissues under the heading of potential modifying factors of plaque-induced gingivitis, and puberty, menstrual cycle, pregnancy, and oral contraceptive drugs also took its place in the new system. So sex steroid hormones, we also call them, because they are chemically in the steroid group of hormones, which define the sexual characteristics of a person. In the females, they're secreted from ovaries, and male from testes. They're mainly estrogens and progesterone in females and testosterone in males. But in the females, estrogen has some subgroups, and estradiol is the most pronounced estrogen that we know, and most of our knowledge is based on the estradiol levels. So, yes, sex hormones have effects on periodontal tissues, for sure. That's why we do this webinar. But effects can be grouped under some headings. For example, we know that they make changes in the periodontal microbiota. Some of the periodontal pathogens may increase, for example. Also, sex hormones can alter or differentiate the vascular characteristics of a tissue. And the inflammatory response can be regulated by the by the sex hormones. Also, fibroblasts and epithelial cells are modulated by the sex hormones. So these four major effects take place in the periodontal tissues. So when we see what testosterone can affect on the periodontal tissues, we see an increase in the osteoblast proliferation and differentiation, also matrix synthesis by periodontal ligament fibroblasts and osteoblasts. Also, there is a decrease in the osteoclast differentiation, and prostaglandin secretion, and some other cytokine production also decreased by the effects of testosterone. When we take estrogen, we see that it is capable of increasing the gingival fibroblasts and polymorphonuclear leukocyte phagocytosis, and also the maturation of connective tissue increases with estrogen cell. But also we know that gingival inflammation is increased by estrogen. On the other hand, estrogen is capable of lowering pro-inflammatory cytokines also, and keratinization, and the chemotaxis of polymorphonuclear leukocytes are decreased, and leukocyte production itself also is decreased by the help of estrogen. And what progesterone is capable of is vasodilation, and increase in prostaglandins, and also increase in the number of polymorphonuclear leukocytes. And also it can decrease collagen synthesis in the periodontal ligament fibroblasts, and also fibroblast proliferation. So, as our first period in specific period in time, puberty, let's say, we are experiencing in some of our patients gingival inflammation. This is gingival inflammation can be seen in any person, but especially in the puberty, we might see a little bit of increase in inflammation without the help of plaque, or very minimal plaque. And in some cases, we can see gingival enlargement also. And it is for the girls, it's going to be the increase in estrogen, and for the boys, it's going to be the testosterone, which is increasing, can change the response to the bacteria in the tissues. So, what science does say about is we see a specific increase in some of the periodontopathogenic bacteria, Progesterone intermedia, Capnostophagus, and Bacteroides species. And interestingly, Progesterone intermedia can use estradiol and progesterone as a growth factor instead of vitamin K. So these situations, I think most of us who are watching are very familiar with. We can see them very, very commonly. This is not a big deal for a periodontist or for a dental practitioner, because we know how to treat it. But we should also take into account that during puberty, these individuals, they are not very good at communicating. They're not willing to, at least some of them, they're not willing to open up themselves and listen what we say or do what as we say. So I think we should take it into account that when we are trying to treat these patients, we should make them believe that this is an important issue. And also, we should include the families into this treatment, and then take their support too, without causing too much stress on our patients, because the parents can also create some stress on their children, especially in puberty. So it can be, as we see, just a mild gingival inflammation as gingivitis, and on the right side, some gingival enlargements can also be seen. When we get to menstruation, menstruation is a totally different scenario, of course. We see an episodic increase and decrease of estrogen and progesterone as a physiological process. this population also can overlap with some of them at least can overlap with the puberty population, because when menstruation starts with puberty, some of them would be seeing some effects through that period also. What again we see is an increase in gingival inflammation, and this is a very very well-known and old study, but still it's very important. This is done in dogs, but what they saw is in gingival clavicular fluid flow by the increase of estrogen and progesterone during the menstruation. So when the estrogen and progesterone was at its highest, the gingival clavicular fluid flow was at its peak levels. So I think it is important to see that as the hormones increase, these hormones and the signs of inflammation might be increasing. But they also saw some other lesions in the mouths of dogs, some aphthous ulcers, herpes labialis lesions, and candida infections also. This is a more recent study from our group. We also checked the estradiol and progesterone levels during menstruation. We did it in 3 time points and checked the pro-inflammatory markers in the gingival clavicular fluid, and the clinical status of the patients were checked. What we saw is we saw that as the estradiol and progesterone increases during menstrual cycle, in the same manner, accordingly, the interleukin-1 beta in the gingival clavicular fluid increases, and also bleeding on probing increases accordingly with these levels, and they go back to normal or they decrease significantly with the decrease of the hormones back to its normal levels. So this is also a case that we all can see almost every day. Nothing so different about it. But the patients usually complain about a bleeding and gingival swelling, even though they're brushing their teeth or they're taking good care of their mouths. So when there's even less plaque, we might see some pronounced inflammatory effects during the menstrual cycle, especially in the days that estrogen and progesterone at their highest. Well, pregnancy is a very special period in life, of course. In pregnancy, everything changes, all of the body, of course, and we see a lot of different effects of it in the periodontal tissues. For example, probing that increases, signs of gingival inflammation increases very much. Also, gingival clavicular fluid flow increases, bleeding on probing, and even in some cases we can see some tooth mobility increase. And pyogenic granulomas are much more seen in pregnancy, especially towards the last stages. And there is another way of looking to pregnancy period. If we take it to the other side, then periodontal status might be affecting the pregnancy outcomes, like preterm birth or low birth weight. So there is some research on that. I will come to that. What we know about pregnancy, what does changes? We know that some pathogenic bacteria increases proportionally as the estrogen levels increase. So especially starting with the second trimester, gingival inflammation and signs start to increase. Once again, in another study, they shown that the subgingival biofilm composition changes to the more pathogenic side, and there's an increase in Porphyromonas gingivalis and especially Proliferalia intermedia, and these bacteria, as they increase, of course, promotes the inflammatory response from the host, and as the tissues are so prone to giving inflammatory response, then we see some pronounced effect in pregnancy. This is interesting, I think. This is another way of looking at things and opens our minds, and because it has been shown that the periodontopathogens can colonize the placenta. So especially starting with the first trimester. I mean, it doesn't happen at very late stages. It happens from the start. So, which means that the periodontopathogenic bacteria, which can cause a very pronounced host response, inflammatory response, they're located in the placenta too in some people. So there might be some effects of it. Also, in the same study, they tried to treat the periodontal condition in the second trimester, which is usually accepted as the safest period. I'm very sorry, but I think I have to correct something in my presentation because I think people don't see it as a whole. Let me do it this way. Sorry for this. Okay, I think this is better now. I'm very sorry about this. So when they treat the periodontal condition during the second trimester, they didn't see any reduction in the risk of preterm or low birth weight, the adverse pregnancy outcomes. So the treatment of the periodontal condition during pregnancy did not decrease the effects of this condition on the preterm or birth weight. So this is something to take into account. So we now know that oral microbiome is connected with the placental microbiome. So if we keep our oral environment as healthy as possible, then it would help to keep the baby safe, even, I mean, more safe at least. So there is some possible mechanisms that trying to explain this relationship between pregnancy outcomes and periodontitis. One being bacteremia, which can cause by just brushing or chewing, or most importantly during dental procedures. Also, the increase of systemic inflammatory markers as the periodontitis gets severe, then it might be affecting the inflammatory response in the placenta. So another explanation is the autoimmune reaction might be started by the oral bacteria, so that these adverse outcomes might be happening. So they advised also that periodontal history, periodontal disease history, and periodontal care should be included in the basic obstetrical counseling to women willing to conceive. So it is a nice thing to do if we can inform our patient, inform the doctors about the possible effects of bad oral conditions, bad periodontal conditions might be affecting the outcome of the pregnancy. So this is one of many cases which we can see during pregnancy. We see a lot of gingival inflammation. We see enlargement of the gums in some places, and pyogenic granuloma might be getting bigger during the time. And this type of scenario, it is possible to treat maybe, but our normal procedures would be maybe a little bit hard formed because of the situation of the patient, or even the stress level of the patient might affect during pregnancy. And with the consultation of the patient's doctor, we can maybe have to continue with the treatment during pregnancy, but at most times, the best scenario is do as much as conservative treatment and do a very well done oral hygiene instructions, and try to keep the patient in contact so that they are continuing on with their oral hygiene, and maybe making short visits to see how it's going if it's possible. So treating periodontitis during pregnancy is an issue, but if we have the opportunity, then we should be treating periodontal conditions prior to pregnancy, which of course will increase the success and increase the possible bad outcomes might come. This is a different story. Contraceptive drugs, they're very common, as we know, but of course this is not a physiological condition, but it is a drug that simulates the state of pregnancy. So it also consists of estrogen and progesterone, and it might have effects on the periodontal tissues, especially the older versions. The concentration of the hormones were much higher, so there were some effects on it, on the periodontal. But in the recent ones, in the current ones, we see much lower dose of those hormones, so the effects are very mild actually, but we can see some effects, some inflammation in the gingiva, but also some bacteria has been reported to be increased when people are using contraceptive drugs. But these drugs have another side. They cause a variation in the coagulation and fibrinolytic factors. So this is not related to periodontal conditions, but this may be taken. This is actually good to know, to take into account when we are planning a treatment, because our treatments causes bleeding. So we should know that contraceptives can cause this kind of variation. So we come to menopause. Menopause is, of course, the another physiological condition in a woman's life. It has some effects, not just on the periodontal tissues, but in all of the tissues. But what we see in the oral tissues is basically dryness, and related to that, we can see oral discomfort in these patients, like burning sensation, or some problems with the taste. And what we see in the gingiva, it's much more pale usually, and in the epithelium we can see some desquamation. But what postmenopausal women might suffer, basically, more importantly, is the osteoporosis. And in these patients, the saliva flow also decreased and keratinization decreases. Yeah. So there are some studies try to connect the osteoporosis issue with the alveolar and alveolar bone loss, and there has been a link actually found. We cannot say maybe a link, but there is a relation. In the osteoporotic women, a higher frequency of alveolar bone height loss is reported, and alveolar density loss is also reported. What we should understand from this is as the density decreases, it's not that we see the alveolar bone loss because of osteoporosis or because of menopause. It makes the trabecula thinner, so that in a case of inflammation, in a case of periodontitis situation, we might see a little bit more bone loss or a little faster bone loss maybe. But in another review, it's been stated that menopause is not a risk factor for women with healthy periodontitis. So this is once again very important, that if we keep the mouth healthy, if we keep our patients' periodontal tissues healthy, which we know how to do it, then there's another risk for those patients in the menopausal phase. So I think we should take this importantly. This is one of patient of mine with in the postmenopausal phase, and we don't see anything too different. It's just more pale gingiva, and there are some abrasions and signs of a little gingival inflammation, yes, but we know how to treat these kind of situations. And if dryness in the oral tissues and mouth is the case, then we can, of course, advise some supportive things that would help with that. So this is not a clinical problem for us or for our patients, but we should, of course, keep it healthy always. In some of the menopausal women, we see that hormone replacement therapy is given. So, which is given basically for the postmenopausal osteoporosis, prevention of it. So, it is consist of progesterone and estrogen again, and it also helps with the signs and symptoms of the menopause, which some of the women suffer. So, this drug is also taken under evaluation in terms of periodontal health or periodontal situations, and it's been concluded that it has some advantages on bleeding on probing. I mean, it reduces it, we may say that, but there has been no effect on alveolar bone level. In a study from our group, we have also looked at the hormone replacement therapy receiving patients who had periodontitis, and we treated that periodontitis situation during the period while they were still receiving hormone replacement therapy. We saw a gain in the clinical attachment level following non-surgical periodontal treatment in a 6-month follow-up period. So it is important maybe to include in our questionnaire that if the patient is taking hormone replacement therapy. So we come to the last hormone and last situation that we should be talking about, the changes in testosterone levels. So no correlation been set in the older males with the testosterone level and periodontitis, also tooth loss. These people were older than 65 years old, all of them, and this is an important finding. But in another study, it is interesting to see that low testosterone level is not associated with periodontitis, but high testosterone levels were actually had an effect on periodontal situation. It also supports, this study also supports the previous one. High testosterone levels promotes a higher osteoclastic activity. So we now know that testosterone has an effect on periodontal tissues, and but it doesn't matter low or high if the tissues are healthy and without any inflammation. So we come to the same point again, that if there's no inflammation in the tissues, if we keep our patient's mouth healthy, and then the risk is not a real risk, actually. So to conclude, I'd like to say that I think we should take into account the effects of the sex hormones during lifetime in our patients, that we should take it to consideration in our questionnaires and during our diagnosis and during our treatment, so that we can understand our patients and we can create more personalized treatments to our patients and be more successful with it. So with puberty, I should say that supportive periodontal treatment is the way to go. And as I told before, I think in this population, communication is a very important part of the treatment. And with pregnancy, I think it is best to say that we should, if we have the chance, we should treat the periodontal situations prior to pregnancy, so that our patients wouldn't experience any adverse outcomes or any discomfort during pregnancy. With people taking contraceptive drugs, yes, it has some effects on the periodontal tissues, but not so big effects. But since those drugs have an effect on coagulation, we should take it in consideration if our patients are taking these type of drugs, so that during our treatment protocol, we can control those effects. And with the menopause, it's not a risk factor for women with healthy periodontium. So we should once again try to keep our patient's mouth healthy. And it is interesting to see that high testosterone levels is associated with periodontitis, but when there is a periodontal inflammation. So if we try to keep the tissues healthy and safe, then the levels of the testosterone wouldn't be much of an issue. So with this, I'd like to conclude my presentation, and thank you to the EFP first of all, and thank you for our listeners, watchers from everywhere, and I hope everyone's safe against this COVID-19 pandemic, and hopefully very soon we will be in the common areas again. Thank you.
Thank you very much, Ali, for the enlightening presentation. We've learned a lot of details. There are some questions I need you to answer if you are ready. Can you hear me?
Sure. Yeah, sure.
Let's start from the beginning of the presentation. There was a question said that during the second trimester and the third trimester, the periodontal pathologies in the pregnant women reaches a peak. Could you explain this phenomenon by integrating the hormones? Meaning probably that we are not going to see a lot of pathology in the first semester, but mostly in the second and the third. Is there a way to explain it with hormones?
Well, the hormones increases gradually, so the effects also increases gradually. We know from those studies that I presented, at least there are many more, of course, and each of these subjects can be talked through separate seminars, as we know. So, but it increases gradually. So with that increase, we see an increased response in the tissues. That should be the answer, I think.
Yeah. Another question is about bacteremia. Given the risk of bacteremia during dental procedures, is antibiotic prophylaxis indicated in pregnant women?
No. As far as I know, no. Yeah, no. I mean, if the pregnant woman, that woman is healthy systemically, it should be taken into consideration of the patient's systemic health, of course, when deciding those type of situations. For example, a diabetes situation might be in our hands with the pregnancy also. So I think we should take our questionnaire very thoroughly, and we should also consult the obstetrician and take their blessing, let's say, for our treatments, and set a good time for the treatment. And but not every pregnant woman should take prophylactic antibiotic. No.
Okay. So another question is about menopause. Is it a risk factor to women with gingivitis or also to women with severe periodontitis? Meaning that if it's a bigger risk factor for gingivitis to proceed to periodontitis, or if you have a severe periodontitis, it's during menopause it's even worse to accelerate the periodontal destruction.
Okay, very nice question. I think someone who deals with these topics asked this. Well, gingivitis, as we know from many studies in menopause and postmenopausal women, the inflammation factors doesn't change so much with the menopause. In some studies, it's been reported that some changes happen, but we cannot conclude from those that if a person in the postmenopausal phase has a gingivitis, then it might proceed to periodontitis easily. But it is safer to say that if a person has a moderate or severe periodontitis, and in the postmenopausal period in life, then and if they didn't receive, and they're not receiving any treatment, any periodontal treatment, then maybe the periodontal tissue loss is more possible to increase in those patients. I think what we know from the research has been done, I don't think we can say more than that.
Okay, great. Another question is which changes we should do on a patient that takes contraceptive drugs prior to periodontal treatment? Are there any protocols, something we should do?
Actually, protocols, I really don't know because I haven't read any. I didn't see in anywhere. But I think we again, a consultation is a good advice. If we are planning maybe not non-surgical periodontal treatment, but if we're planning any surgical treatment, some values some blood tests might be needed, like prothrombin time or bleeding time, and those can be seen, and a consultation can be made with the physician, so that if it is so necessary, anything shows that bleeding capacity is higher than usual, then maybe there can be a cessation of those drugs, and then we can continue with the treatment, and then the drugs can start again.
Okay. Another question, interesting, is could ethnicity have any role on how much sex hormones affect the periodontium? Do we have any data on that about the
I'm
ethnicity?
very sorry, but can you repeat that, Spiros?
Could ethnicity have any role on how much sex hormones affect the periodontium? I mean, the race on the hormones which affects the periodontium. Do we have any data?
I think no. I haven't seen any research done based on ethnicity in the effects of sex hormones. So I don't know actually, but it's interesting for sure. I mean, if it affects or not.
Okay. Another question is about antibiotics, about the use of metronidazole. Could we recommend it? When? How? Or do you have, to extend the question, any recommendation about antibiotics if we need to prescribe them? Which one and when? When is the best time?
Well, this is, I think, out of the topic of this webinar, but because I don't know any relation with the sex hormones and antibiotic usage, but actually it's hard for me to answer this question, because I don't know in what type of situations they're asking to or not taking the antibiotics. So, but what I can say is I don't know anything that sex hormones related usage is defined.
Okay. Another question I would like to ask is about chlorhexidine use during pregnancy. I know that I'm also afraid I don't prescribe chlorhexidine during pregnancy. Do you have any?
Either.
You don't.
I don't either. I don't either. I mean, it's not me because sorry.
Yeah, it's possible to create.
Yes, from the same reason actually, because we know that. I maybe it doesn't have so much effects, but I wouldn't risk it.
Yeah. Another question is the increase in Prevotella intermedia on puberty related with host response or a type of biofilm change?
Wow.
That's
okay.
a very that's I wanted to make it for you. I want I like
that's
tough exam.
Coming from yeah, that's coming from a person with strong microbiome background, which I am not that much. So, but now what we know today is it egg from the chicken or chicken from the egg situation. So microbiome is affecting the host response, but host response is actually changing the environment for the microbiome, the microbes to live in. So as the host response changes, as it increases, and all of those secretions made from the cells, the microbiota also changes, because some of them cannot live in that situation, and then the others come and takes place. So that's what I can say.
Another question is about smoking, if there is any effect on the hormonal changes inducing to hormonal-induced periodontitis. I mean, if smoking maybe do the worse.
Well, smoking make it worse. We know it already, right? So, and yeah, but with the changes in sex hormones, does the smoking has another effect other than its own effects? I don't think so that we have such data on that.
Okay, so another question, a clinical question is, if we have, it's my own question, I mean, we can see that a lot of problems in pregnant women are tumors, pregnancy tumors, epulis. Yeah. And yes. Sometimes it's bleeding, sometimes they cannot eat properly, and maybe they create a stress to them. When it's the right time to do it, and which is the best way to do it? I mean,
you mean are we? Are you? Them? Yeah, remove them. Okay. Well, I think the case is important. I mean, how big is that, and where is it located? Does it affect? What does it affect actually? I mean, does it affect eating? Does it affect speaking? Does it affect the aesthetics? Or who is this person? I mean, what type of life is he or she living? So we, of course, try to be in the conservative side during pregnancy when we do our treatments, because when we do the at least basic cleaning and oral hygiene instructions, then we achieve improvement in the cases. And this might be enough for some cases. Then, because at the end of pregnancy, we know that those tumors would be collapsing and be smaller and smaller. And if it stays still, then we can do our surgery. We can remove them after pregnancy when it's available. But when it's a huge issue, as a very big one located in a very important place, affecting the patient's nutrition or the function in any way, then it is important to keep the pregnant woman in a healthy situation so that we might be removing it during pregnancy. So I think it's a very, very sensitive decision to be made over there, but we shouldn't rush it if we don't have to.
Great. And let's have one last question, because there are so many and the time is passing very quickly. Yeah. It's about, again, mouth rinses. Do you prescribe hydrogen peroxide, which we know now it's very in fashion because of the coronavirus?
Yeah, exactly.
In pregnancy, could you suggest hydrogen peroxide?
No, I don't do it. It's not done in the environment, I mean, in our clinic. But can it be done? It can be done. But we should, I mean, I don't think that first choice of advice to those patients would be the mouth rinses or any chemical agents. It should be the oral hygiene instructions, keeping them under control, more maybe, and the connection with the patient is very important to continue on with their cleaning, daily cleaning and daily routines, and maybe some cleaning in these people would create much more gain than the mouth rinses or any other kind of supportive chemicals.
Okay, thank you very much. We answered as many questions as we could. It was very, very presentation of Dr. Çekici. So let me, before we close, let me share with you 2 slides. Let me promote the next webinar, which is going to be one, again, scientist from Greece, this time, Danaia Batsidou, who is an assistant professor in Aristoteles University in Thessaloniki. And he's going to present a very nice topic about tissue-engineered biocomplex for clinical periodontal regeneration. And this is going to take place on Thursday, 4th of June at 1900 Central European time. And it's going to be moderated. Let me show you again. It's going to be moderated by Nicola West, who is, of course, the General Secretary of the EFP and also the Treasurer of EuroPerio 10. And we know that nowadays, if we want to have a proper seminar, we have to tell something about COVID-19, but this is something really important. It's a document, actually, where it's a protocol with suggestions given to clinicians how to manage patients before, during, and after treatment in order to maximize safety. And that recommendations have been coordinated by Filippo Graziani, the EFP past president, and of course a very well-known and established Italian periodontist. Although you can find those recommendations at the EFP website, and you have to keep in mind, of course, that those recommendations does not conflict with any guidelines issued by local and national healthcare authorities. And I know that there was at the email we sent you just before the presentation, maybe there was any mistake in the link to go to webinars, but I see that we have a lot of participants. And I want to ask from all of you to follow the EFP on social media. And I would also like to thank you for being here with us today. And till next time, stay all safe. Καληνύχτα. Good night.